let's then turn to the Chief Executive's report. Over to you, David.
Thank you. I'd just like to talk a bit about the changes around the 1st of April and the implications of those for all of us. I want to talk a bit about the response of both the government and the NHS England to the Francis report. We had, I think, a really good discussion at our last meeting around all of that. And I want to talk about a couple of issues, I think, which are very significant in the sense that they show the move between being a organisation in setup to one which is actually taking operational responsibility. So I want to cover 111 and I want to cover the Leeds Children's Heart Centre. So, 1st of April, change of name, but not responsibilities. The executive team overall took the commitment that we would visit all of our staff and meet with all of our staff over April, and we're doing that at the moment. We're going to visit each of the area teams. I've done 5 of them so far, and we've literally met hundreds of staff to talk about the NHS England, what we're trying to do, talk about the business plan, talk about our mission, vision and values, all of those things that you'd expect us to do. They've been really, really good meetings so far. We have got a fantastic group of staff out there who are really keen to take services forward. The issue of the name change has been really well received by staff, and I think it's an important part of it just to set out. One of the things that sometimes they misunderstand what the NHS is, in the sense of people sometimes think it's just a set of organisations who will kind of work together through contracts and relationships and all of that. But actually it's the people who work within it. And the thing that binds everyone together is the kind of the values and principles that people hold, whether that be around the importance of putting patients at the centre of what we do, or around everyone counts, that not only are we responsible for delivering services to patients, but also that we need to make sure that those people who have difficulty connecting with the NHS for a whole variety of reasons, many of them not their own fault, we make extra efforts to make sure that we support and help them with their health and healthcare. And those values and principles are kind of enshrined in the NHS Constitution. And of course, one of our main responsibilities is the promotion of that NHS Constitution widely, both in the NHS and beyond in society. And people genuinely believe that the kind of name connects that in a much better way, a much more accessible way to people as we go forward. And I think so, certainly if you talk to us, I'm sure we will do, talk to our staff around, you can see how committed they are to that kind of work. And I think we've got, as I say, a really great bunch of staff, and we're going to continue to do that as we go forward. An important part of what happened towards the end of the last financial year, as the old organisations were closing down, was the publication of the government's response to Francis. And as part of that, all of the various organisations, constituent organisations around the NHS, both regulatory and management and commissioning, they all signed a statement of common purpose. One of the most important things, lessons in a sense, from the past is how organisations work together for the benefit of patients, and that enshrines that in that. And we were engaged and involved in conversations around that, the government's response. And it's really important as we get into implementation of changes that need to be made, that we continue to work collectively together. It's what our communities and our patients expect. And the NHS England has a major part to play in all of that. We kind of heralded quite a lot of that in our planning document, Everyone Counts, which set out, I think, a really set of important objectives that we want to deliver. It's kind of reflected in the business plan, which we're going to discuss a little later. And I would just particularly say that obviously inspection and all the sorts of things that are in the government's response are really important, and we're really key to take forward. I think our particular response, our particular role in all of this is on the one hand to inspire and motivate the people who work within the NHS. And I think the CNO strategy and the work around that is a really important part of that, and we're sponsoring that and taking that forward. It's set out in the business plan. And also giving patients more power, more clout in the service, which again is reflected in the business plan. I think in those ways we will make our big contribution to taking the NHS forward. It was always going to be a challenging time, I think, for us when we moved from setup to operation. And if you think about the scale of the operation that we're responsible for, or the commissioning of that, it is very, very, very significant. And I just want to identify a couple of things I think that have happened relatively early on. The first one is we took operational responsibility for 111, which had been planned for some time. And there's no doubt that there have been some significant operational problems in putting 111 into place. We've had serious difficulties in relation to people being able to get through just simply in terms of call handling and the phone arrangements, and we've had a large number of, in some places, people who have had to give up and try again later, and that's clearly unacceptable. And we've let some of our patients down, and we need to think really carefully both about the lessons we learn about how we do that, but also, more importantly at the moment, to get the service up and running. And we took a decisive action at the beginning of April, led by Barbara and her team, putting into place a set of contingencies that we'd planned, that we'd had got available for us, but they continue to operate. And we can see that the service is, and we are monitoring on a daily basis, improving at the moment, with one or two areas where we've still got issues to deal with. So we need to get that stable, and we're working really hard to make that a reality. And as I say, performance is improving on a daily basis. We also need to kind of reflect, I think, in time around what we should do around some of the failures that we've had, particularly around the providers of service, which have simply not delivered what was expected. So we need to make decisions about what we do with that. And I think we need to think more long term about what is the kind of service we really want for our patients going forward, as well as, I think, having a pretty good reflection, a deep reflection on what we could have done better to make it a more successful outcome for patients. So all of that is being taken, all is being taken forward, and we'll bring all of that to board meetings in the future. The second area is around the Leeds Children's Heart unit and the work that we have done around all of that. The first thing, I think, I personally would commend the work that Sir Bruce did when faced with a set of information. There was some data, but also some what I think might be described as soft intelligence around what was happening in the unit. What Bruce did in those circumstances was meet the unit, meet the people who ran the hospital, in a sense hold a mirror up to those people about what was happening, and they agreed to suspend operations during the next period. And then we were able to put into place the process that had been identified by the National Quality Board, one of the sets of processes that came out of the original Francis report, about what do you do when you have intelligence that something might not be quite right in an organisation and patient safety may be at risk. And we put in a group of people to investigate what was happening. We also set up a series of risk summits involving all of the organisations to enable us to make sure that at the time when it was right to reintroduce surgery, that it was done in the safest and most organised way. And I think that's what essentially is happening. Throughout all of that, our responsibility as NHS England is to absolutely clearly put ourselves on the side of safety and the children, and I think that's what's happened over the period. We're not, by any stretch of the imagination, at the end of this story. There is still quite a lot of work to be done by the Leeds Children's Heart Centre to improve what they do and to give both themselves as an organisation and the wider community assurance of what they're doing, but we're satisfied that we are in the right place now in terms of taking that forward, and that it was the right thing to do to reintroduce surgery. So there are two big operational issues that we tackled. I'm sure it's the beginning of many, and again I think we should kind of take the opportunity to stand back at some time and reflect on what we could have done better, what lessons that we learn as an organisation as we take this great responsibility that we have forward.
Thank you, David. I'm absolutely clear that that's right, and we have to do a very serious appraisal of both 111 and Leeds in terms of lessons learned for NHS England. But I would like, if I may, to ask Bruce Keogh, our National Medical Director, to perhaps say a little bit more about the Leeds experience.
Well, thank you, Chair. If I could just put a little context around this. Children's heart surgery is some of the most technically and intellectually demanding surgery there is. There are new operations which are being performed now which didn't exist 20 years ago. We have babies that are getting much smaller because we're operating earlier on them. The post-operative care as a result is much more complicated than it used to be, both in the intensive care unit and in the ward. And both professional and public expectations of good results are growing. And that's resulted, I think, in widespread agreement that it makes sense to concentrate expertise in fewer units. And we believe that we should do that in the pursuit of excellence and in the pursuit of future-proofing an increasingly complex medical and surgical specialty. And that gave rise to a program called the Safe and Sustainable Program, from which I need to be absolutely clear I've been utterly independent since its inception. But 2 weeks ago, I was confronted with a number of issues which coalesced. Firstly, a surgeon had been taken off surgical duties in Leeds. Secondly, most of the operating was being conducted by locum surgeons because the senior surgeon in Leeds was away on holiday, and there was a long weekend approaching with Easter. In addition, I was approached by a surgeon from Newcastle who reiterated some concerns which had previously been expressed by the Children's Heart Federation, in which they had communicated with the Care Quality Commission, that they felt there were issues around the way patients attending the service in Leeds were given access to choice of where they might go, and questioning the quality of advice that some of them had received. And then the final thing that happened was that Sir Roger Boyle, previously a highly successful National Clinical Director for Cardiovascular Disease over the last 12 or so years, sent me some risk-adjusted data, albeit early, which showed that the mortality rate in Leeds was 2.75 times the national average, and that there was clear blue water between Leeds and the other units, that the mortality rate was rising. And that, to my mind, was the final thing that made me think that we needed to do something. And the irony of it was that this information all coalesced in the same week that the government responded to the Francis inquiry. And one of the things that the Francis inquiry had in common with the Bristol Royal Infirmary inquiry into children's heart surgery some 13 years ago was that when confronted with data, people argued and dithered over the meaning of the data and its utility, and meantime, patients were being harmed somewhere else. So it was against that background that I thought our options were limited. I and colleagues met with the Trust. We, as David Nicholson says, we held up a mirror to the Trust, and I think everybody agreed that a sensible approach would be to pause, not close the unit, simply to pause surgery in that unit. And it's my belief that if we hadn't done so, and something had happened over that long weekend, we would be having a much more difficult conversation than we're having at the moment. So this pause was in the interests of the patients, of the families of those children in Leeds. It was in the interests of the surgeons, and it was in the interests of the Trust. So there were two steps to what we undertook. The first was we needed to review the mortality data to check its veracity and validity. And secondly, we needed to review the unit. Now, in the process of reviewing the mortality data, it became absolutely clear that Leeds had submitted incomplete and inadequate data. Now, it's my view, and I need to be clear about this, that people undertaking surgical and other procedures in our NHS have a duty to be able to describe what they do and define how well they do it. Otherwise, I think they forfeit some of their professionalism, and this applies both to individuals and to organizations. So Leeds had submitted inadequate data, and to give you an example, you need the weight of a baby to be able to work out how risky the operation is in taking account of case mix in the analysis. And the weight of the baby were missing in a substantial number of records submitted by Leeds. And in fact, that missing data was 20 times worse than any other unit in the country. So we corrected all of that data, and it was submitted and reanalyzed. And I'm glad to say that once things had been reanalyzed, Leeds came back into the envelope of a normal national mortality rate. And it's against that background that we've been able to satisfy ourselves that the immediate issues of safety, I think, have been pushed to one side. The second thing we did was a review by experts who understand children's heart surgery. And they spent a fair bit of time interviewing people in Leeds and visiting the unit and understanding the environment in which the surgery was undertaken. And they took a view that what they had found, combined with the newly submitted and reanalyzed data, that it was reasonable to recommence surgery. All of these issues were discussed at a risk summit, which is part of the process which has been defined by the National Quality Board, where NHS England, the Care Quality Commission, the Trust Development Agency, and the hospital were all represented. And it was at that risk summit that the agreement was taken to recommence surgery. But I should emphasize that there are still some unresolved issues that remain, which don't have the same level of urgency. First of all, the Children's Heart Federation and Newcastle have raised issues about referral and access to other units. Now, when surgery is very, very complicated, there are some units which have better expertise at performing certain procedures than others, and that's normal. And referral for different cases to different units is normal in all aspects of surgery. Secondly, we're looking at how complaints had been dealt with by the Trust, and there is a case note review going on where there are issues of concerns about treatments of children in the Trust. So there is a further risk summit to take place in the near future in a week or so, where these additional issues will be considered in the light of further emerging information. Thank you, Chair.
Bruce, thank you for that explanation. May I invite members of the board to raise any issues or questions, both on David's report and on Bruce's addition? Nagib and Ed.
On both of these issues, I think it would be really helpful to be clear about what is the scope of our responsibility as NHS England. So on the 111 service, do we run everything? Is it staffed by people who work for NHS England, managed by us? Is any element of it outsourced, or is it something that we are totally responsible for across the country? And on the Leeds thing, in a similar way, to understand, so Bruce, when you were involved in the decision, was that in the context of your old role as medical director, or was it as NHS England? And in making the decision to suspend operations, do we do that because it's a specialist service that we're commissioning directly, or is it because you're using some other kind of instrument or lever in either your individual role or the structural setup between NHS England and the trust that you talked about that runs the hospital? And I think in these examples it's quite useful to be really clear about what are we really responsible for, what do we control, and how did we exercise that responsibility.
Thank you. Just before you answer, Ed, is your
It's
intention
connected
on the same?
in a way, and it's sort of David talks about lessons learned, and I think it's really important that we learn lessons, but balanced with that lessons learned, I think there is being clear about accountability, and that's not in a witch hunt sense, but you know, we have to be clear that we will hold providers and suppliers to us accountable, and we will hold ourselves and our people accountable for the responsibilities and obligations that we have. And I think that that is a key part of learning lessons, but holding accountability as part of the system.
Okay, David, you might. Oh, just sorry, before you respond, Victor.
Well, two slightly different points. One was on the Constitution.
In which case, may I take responses? Moira, is yours on?
It was just, again, I think the public don't have very much information about the whole 111 planning, and you know, it's, and probably didn't pay very much attention. If I count myself as a member of the public, didn't pay very much attention about the rationale behind it, the financial savings that are intended to emerge from it. And I just wonder again if David could address the issue about who should be doing that explaining. Is that our responsibility?
Okay. Just pick up one more, Margaret.
Yes, it's tangential to Maureen's point, and that is that if we are looking at the responsibility on 111, the contingency arrangements for the cutover need to be very, very clearly covered within business planning of the responsible entities, and that's something that I'm not sure has actually been articulated as clearly as I'd like to see, because you know, obviously it's that cutover that's the vulnerable element. If 111 fails because it's new, that's one aspect. If the existing arrangement still subsists and one needs to make a business plan provision for that subsisting cover, that's another element, and that needs to be clearly covered and dealt with. Chairman, I do have another point, but
May I hold? I'd quite like them to take together all the points about 111, and Barbara may wish to come in as well, and then separately the points about Leeds, and then we may move to other points.
I'm sure she will. And of course, the complexity of the 111 position is, of course, we moved systems halfway. The statutorily organisations moved during that period. The original idea behind 111 was that the urgent care system was becoming more and more complex. That as things like minor injuries units, urgent care centres, out-of-hours services, a whole plethora of things were becoming available to patients, it was more and more difficult to make sure that the patient got to the right place as fast as possible. And the idea behind 111 was this was a mechanism by which, or one telephone number where people could ring up and they would be, in a sense, directed to the right place in the system as fast as possible, so they could access that service really rapidly. The responsibilities for that were given to originally the PCTs to do, so they're commissioned in a whole variety of different ways, and they've been transferred over to the clinical commissioning groups. And there are, I think, 46 different contracts being let on 111 across the whole country. Locally, those contracts were let, and in a sense, that's what we've inherited. That's what we're responsible for now, the oversight of that. Not for the commissioning, we don't commission it directly ourselves, and it's being commissioned in those places using a variety of providers, from NHS to the private sector to the independent sector. So there's a whole variety of providers as well. And I think this is one of the lessons I think we're going to have to think about when we take all of that forward. And our role in those circumstances is the oversight of it to make sure it's put in place. But I think Barbara wants to add.
Barbara.
Yes, thank you. I think in answer to your question there, that we certainly don't employ the staff because it's a service that CCG's commissioned. As David said, there's a range of providers. The commissioning of the service transferred on over the bank holiday weekend from PCTs to CCGs. And what was apparent, as David said, is that patients weren't getting a satisfactory level of service from this service, which was being rolled out across the country with different sites going live and different sites taking on more responsibility at different times. So at that point we believed that our role was to support CCGs as commissioners, because I think NHS England's role in supporting all CCGs across the country to commission services to be the best they can be for their population is really important. And I think, given the magnitude of the issue and the concerns we had about it, it was right that we stepped in to support them, and I think that support from CCGs was hugely welcomed. So in the run-up to Easter, I set up a national group to give oversight and support to the CCGs in this commissioning. There is no doubt that in many instances it was about providers failing to deliver the service which had been commissioned, and there were issues with the number of staff that providers had secured. As David said, a range of providers, some of them NHS trusts, some of them not. I felt that in our role as commissioners we need to do a broad range of things to secure the service. Now, part of that was holding the providers to account, and robust discussions went on both at local level with the CCG leaders and our area team directors talking to the providers from the 46 sites, but also at national level, because on a number of occasions there was one fairly large organisation which had several sites, so there were discussions at national level between me and the leaders of those organisations about how the providers could deliver what they had agreed to deliver. But we also felt that in our role as commissioners it was important to do the other things to put around those providers in order to secure the service for patients. So that was about bringing in contingencies, in some instances where it was possible, using other providers to help with the call handling. In some instances where there had been a very recent switch from the local out-of-hours provider and the old NHS Direct system, it was actually about, because we could, be actually reinstating those services to take the pressure off the new 111 system whilst they got up to speed and actually got their call handlers in place. So I think that was what I think as our role as the supporters of CCGs in the commissioning of this system, and in making sure that we did everything we possibly could as a commissioning system to support those providers to deliver the best services for patients, and where necessary using alternative providers. I do think that my focus from 2 weeks ago was absolutely operational delivery, and particularly to get the best results we could over the Easter weekend. And with certain exceptions, we had a significant improvement of the service over that time. That operational focus will absolutely continue to make sure we use all the mitigation and contingency, but we have now, I think we need to talk as a board about how we review the whole of the 111 service. I think we have 3 questions that we should ask. Firstly, was the design and specification of this service right to actually deliver what we want for patients? Secondly, was it commissioned appropriately? The way that this was commissioned, was it commissioned to specification? Was there more that could have been done on a national level rather than a local level? There are many benefits to local commissioning of these services, but we need to think about what support. And then finally, where providers have not, which providers did not deliver the service that was commissioned, and actually what we do about those providers if there is any suggestion that they're not going to be able to recover that provision quickly. So I see that as the next phase of what NHS England needs to do urgently. But as I say, it's certainly not as the provider of service, it's not even as the commissioner of service, it is in our role in supporting CCGs to commission their services for their patients.
Who originally designed this new setup and authorised the transfer? Was that NHS England or somebody else?
The design of 111 has been many years in the making, and was the kind of phased rollout and the decisions to make that PCT should be the local commissioners, that it should transfer to CCGs, and the specification for the service was concluded before NHS England took this over.
I'm conscious that time is running against us. We can all be clear that 111 will come back to the board, because I don't think there's just lessons learned from how it's been handled, but it's how we handle this in the future. And I mean, I think it's a unique opportunity to do something which is not to be found elsewhere in the world, can only be done through a National Health Service, but which needs to be done rather better than it's been done so far. Okay, then we maybe now turn to Leeds and invite Bruce to respond to the points that have been raised.
Thank you very much. At the time that I had discussion with Leeds, I was both NHS Medical Director and National Medical Director for NHS England. By the end of the long weekend, when the deliberations had happened, I was the National Medical Director for NHS England. So there was a period of transition. I would like to be absolutely clear that it was the Trust that made this decision. I had no authority in either role to force a decision in one direction or another. But when I sat down and held up the mirror to them, they will have been aware that I was Medical Director of the Commissioning Board. They will have been aware that I was a cardiac surgeon with a national and international track record in outcome assessment and quality measurement in heart surgery. And they will also have been aware that my only interest was in the safety of children, and that there was no other interest in my mind.
Is it a direct commission service that we're responsible
It is a direct commission service now, yes.
Ian?
Is it just worth me adding to that, while I was sort of coordinating the operational side of the sort of risk machinery, I did write on behalf of NHS England to the Trust on 3 occasions over the period in question, setting out our position both as a commissioner of this service, but also to summarise the actions of the risk summit machinery that we'd operated under the National Quality Board model that Bruce described. So I think we were engaged in this in the way that we would expect to be engaged in such issues going forward, both as a commissioner, but also as a body that has an interest in bringing the system together where concerns have been raised through our regional and area teams and the medical and clinical experts within those to understand risk and then to set it out in a way that it can be addressed.
Margaret.
I'd just like to know whether the Risk Summit makeup included an element that would actually give the right communication management for relatives of the patients, because the feeling that I got from the way in which the messages were coming out over that weekend, the last couple of weeks, was that patients' families felt that they didn't really know what the rationale for the pause was, albeit that it seems a very sensible and cautious move, and that the Risk Summit handled it appropriately given the data that they received. And we have to focus now not just on listening to patients, but also to informing them. And I'm not sure that latter part has really given the information in the way that would give the necessary comforts.
Do you want to answer that?
So I think we were attempting in what was obviously a pretty rapid phase to try and communicate clearly our position. I think we did try to put press releases out. We've attended meetings in Leeds to discuss the issues as they've been emerging. But I guess one of the things that we might want to do then, in the light of the points that have been made about reviewing processes, is to have a look at that issue, because I do think communicating what are often fast-moving, but at the same time really quite complicated, often data-driven issues in these circumstances, but also that touch real people that we're really concerned about, is something that we really need to take seriously. So I think the actions were we put a lot of effort into that, and there was a lot of work done on communications, but I think if we're looking at processes, it would probably be worth looking at that specifically.
Thank you.
Thank you. Margaret, you had another question, I think, related to something else?
No, that was my
That's it.
additional question. Thank you.
Victor.
I was just thinking about this in relation to the work that we want to do on making outcome data for surgeons more transparent, and I'm wondering what the implications of doing that will be in the light of the Leeds episode, and you know what we might learn from a Leeds episode that might help us when we do make surgery outcomes more apparent. And the other question I was going to ask, which is related, is more about the NHS constitution point that David made quite some time ago now, which is that the NHS constitution is a good thing, but it's only as good as people are aware of it. And I just wonder how we are going to make it a clearly breathed in set of principles that staff and the public know about. And it could be just me. My sense is that hasn't landed yet. And maybe there's a plan to test it and do it, but it's not clear to me that it's, because it's only going to be as good as the first time somebody doesn't do it. And then the question will be, well, what happens? And I'd worry about nothing happening, and therefore, well, destroying the good work of the Constitution. So I'm really keen on how we're going to make it live, really.
Shall I ask Bruce to address the first question on outcomes data?
Yeah. One of the things about publishing data at an individual clinician level is that it forces people to think about their outcomes and all the things which will lead to good outcomes. So it's that reflection that it introduces into an individual's practice that is so important. The issue with pediatric cardiac surgery is quite tricky because there are about 150 different types of operations which are relatively commonly done. It means that any surgeon is doing relatively small numbers of different mixes of operations. And because of the complexity, it's quite difficult to compare apples with apples and oranges with oranges unless you have big enough numbers. So my sense is that what is really helpful is to publish the data on children's heart surgery at a unit level, which we've done for some time. But what's been new in this whole process is that we now have a way of measuring and comparing outcomes which has been developed in this country and which is world leading, which I think enables us to compare units pretty effectively now. So the difficulty that we had was that much of the data that we were looking at was out of date. So in terms of the warning data was almost a year out of date, and that's one of the reasons why we had to conduct a review in the unit to see what had happened in the immediate past. So we've now given every children's heart surgery unit some new software to enable them to compare their risk-adjusted results and to see how their results perform on a day-by-day basis.
Because if it was my kid, it relates to Margaret's point in a way. If it was my kids, I'd want somebody to explain to me which were the best units in the country for delivering the kind of surgery that my kids wanted, and I'd want to go there. And I wouldn't really care whether it was Leeds, Newcastle, or anywhere else. And I guess that's the point, really. My other point is, are we expected as a board to endorse the actions that we've taken? Or I know it's what's happened's happened, but is the role of this board to say we back Bruce, or indeed not? Or is there something else that's...
Can I come to that when I...
Right, sorry. Just
do you want to... There was a point about the NHS constitution, Victor, that you raised.
Yes, just...
Before we do that, can I just follow up, because I think it's a theme in a sense about accountability. Bruce has just described the information being inadequate, really. World leading in one sense, but the actual individual information that you were dealing with was a year out of date. Who is responsible in this more complex system that we're now going to work in for making sure that isn't the case in the future, as it were? Where is the driver on the information front about it being timely and relevant.
We're working on that because this is not just an issue that pertains to children's heart surgery. It's an issue that pervades many aspects of data in the NHS. So sticking with the children's heart surgery as an example, the first thing is, I think I've made it quite clear in my previous remarks that it's up to individuals and organizations to be able to describe what they do, define how well they do it, and that means collecting appropriate and reliable information and submitting it to the national clinical audits in a timely way. So I think there's a responsibility on those who deliver services to collect appropriate information, to submit it to wherever it's meant to be submitted. We at NHS England now have responsibility for the national clinical audits, and we are already actually in discussion with them about how to make this more timely.
Thank you. NHS Constitution.
Yeah, the only thing I would add, you're absolutely right, Victor, about the NHS Constitution. I should say that, you know, literally tens of thousands of members of staff and patients are involved in the development in the first place. It didn't spring out of I think, so there has been quite a lot of work. We did quite a lot of work when we reviewed the Constitution about, in a sense, it's how many people knew about it, both patients and staff, and it wasn't as many as you would want, and we'll be bringing proposals to the board at some time in the future about how we're going to lead that work, the campaigning or whatever it is that need to be done to ensure that all patients understand what their both rights and responsibilities are in relation to the Constitution. And I think it will be a thing that we'll need to come back to on a number of occasions.
Thank you. And the same will be true, I think, of the experience at Leeds as an exemplar of the way in which, for the future, we would approach a similar set of circumstances. It strikes me that the critical approach of NHS England is that this is around outcomes for patients. That is our obsession. We will turn to that in the next two papers that we're going to be looking at this morning. Secondly, outcomes can be measured by data, but it is a mistake always to become obsessed by data. Data are by definition historic. They may convey very little about what's actually happening at a particular time in a particular unit. And it's important, I believe, that the National Medical Director is not only looking at evidence which is derived from data, but other sorts of evidence, such as whistleblowing, soft intelligence. The very factors that failed to penetrate the carapace of officialdom in mid-staffs. And I think that those are critical indicators of something going wrong. Thirdly, and to come to the point of remit and responsibility, as Bruce has made clear, his relationship with Leeds was one of, as it were, showing a mirror to them as to the consequences of the data which they themselves had submitted and which demonstrated an outlier effect against the other units. And it was the decision of Leeds themselves to take a pause and a decision of Leeds on further advice over the weekend to resume surgery, albeit with certain constraints. It does seem to me that it's absolutely critical that the stance of NHS England is precautionary. Nothing is lost by being precautionary, and much can be gained if it's handled appropriately. We're, however, conscious that this sort of intervention occurs within an arena that's enormously politically and emotionally charged. Patients have a great deal at stake, providers have a great deal at stake. And that, I think, brings me to the final point of how important it is to be clear about what is the role of NHS England and to ensure that patients are well informed about the reasons for the intervention and the extent of the intervention. I think absolute clarity and reassurance are needed in everything that we do. So we will have a lessons learned. We need to learn from this as to how we would respond in similar circumstances elsewhere, and to be absolutely clear about process and the openness and the transparency of the operation. So thank you. On that note, I would propose that we move on to the next item of business,